And I am the founder, CEO, and medical director of Anova Fertility and Reproductive Health in Ontario. And I am also a reproductive endocrinologist and infertility specialist, so I specialize in issues of fertility and women's health. So today I'm going to be talking to you about the common causes of infertility, as well as the therapeutic options for the management of these issues. Our number one, age. Then there are certain diseases and conditions that are related to the occurrence or the prevalence of infertility. There are ovulation dysfunctions. There is tubal infertility. And finally, problems with the uterus and the cervix, or anatomical issues that are linked with infertility. So the number one reason we're seeing an increase in the prevalence of infertility issues is because women are actually having babies later. So we are physiologically born with the maximum number of eggs that we'll ever have, and that's approximately 1 to 2 million eggs. Egg quantity declines with age. So by the time you've reached the first menses or menarche, women have depleted that egg supply down to 400,000, and then by the time a woman has reached the age of 30, she's depleted her ovaries of 90% of her eggs. The good news is that the 10% that remains is still relatively well functioning until the age of 35, where women are considered to be of advanced maternal age. By the time a woman reaches the age of 40, she's depleted her ovaries of 97% of their eggs. The issue is the 3% that remains is relatively poorly functioning from a fertility perspective. So what are some of the solutions for this? We can, in anticipation of this physiologic diminution of the number of eggs, is that we can freeze eggs early, so we can cryopreserve fertility for future use. We can also, if we are seeing women's ovarian reserve, both not in just quantity, but also the quality that diminishes with age, we can also do fertility treatments, advanced reproductive technologies, such as controlled ovarian stimulation, and intrauterine insemination, or in vitro fertilization, where we actually take eggs and sperm and put them together in a petri dish in a laboratory. And both of those things have been shown to increase live birth rates. And then finally, if a woman has reached the end of her reproductive ability by virtue of egg quality and quantity, there's the option of using donor eggs from a much younger egg donor who doesn't present with any of the physiologic manifestations of diminishing egg quality or quantity. There are certain conditions or diseases that I see as a gynecologist and reproductive endocrinologist these issues are intimately linked to the manifestation of infertility, that is, not being able to conceive for a period of 12 months in spite of concerted trying with timed intercourse. So one of those is endometriosis. Endometriosis is where we see some of the lining of the uterus, so the endometrium, which is located in ectopic locations. So it grows in the pelvis or fallopian tubes, or manifests itself on ovaries as a cyst called an endometrioma. And that is associated with infertility. It affects approximately 6 to 7% of women. So one of the solutions for this is to move on to IVF, to minimize the time that endometriosis has an opportunity to ravage a pelvis or impact someone's future fertility. Another way of doing this is, if the patient is not wanting to conceive, is again cryopreservation of eggs for future use, for preserving their fertility. Another issue that we see that's associated with certain diseases or conditions that are linked to infertility is cancer. So patients who have to undergo pelvic treatment of cancers with chemotherapeutic regimens or radiation, it's not just only pelvic or gynecologic oncology, but just generally breast, ovarian, any type of cancer that requires those chemotherapeutic or radiation treatments will impact future fertility. So what we can do is cryopreserve eggs prior to the first exposure to chemotherapy or radiation. And then if someone hasn't had the opportunity to cryopreserve eggs prior to treatment, there is always the option of using an egg donor. And if it's a gynecologic cancer that requires the removal of the uterus, we can combine both an egg donor and a gestational surrogate for management. And then diabetes. So there are certain issues that we see quite frequently with our diabetic patients, either manifestations associated with hyperinsulinemia, such as PCOS, or patients who are not euglycemic, so their sugar levels are difficultly controlled and they can't carry a pregnancy. And so either oligoovulation that we have to time or control the ovulation, stimulate ovulation, and combine that with exposure to sperm, or if a patient is hyperglycemic or not euglycemic, has an elevated hemoglobin A1C that is greater than 6.5%, we can actually do assisted reproductive technologies, stimulate their ovaries with controlled ovarian stimulation, extract the eggs, fertilize them in vitro, and then cryopreserve them. And once the patient reaches ideal glycemic control, then at a later stage, we can transfer the embryos into the patient. But we see a lot of women who have ovulation dysfunctions, of course, that we know that their ovaries can work, but the way that they are firing is not conducive to fertility. So one of them is polycystic ovarian syndrome. It occurs in approximately 7 to 10% of the population, and it's associated with oligoovulation, hyperinsulinemia, sometimes polycystic ovaries, and then sometimes either clinical or biochemical hyperandrogenism. So that's one of them. The other one is hypothalamic dysfunction. So that's at the level of the hypothalamus, where GnRH actually is elucidated and goes along the synapses and connects with the pituitary gland. If there's any disruption or impact on GnRH's both frequency and amplitude of pulsing, there will be an impact on ovulation. Another one is premature ovarian failure. So we see women who stop having their menstrual periods before the natural age of menopause, which is approximately 51 years of age. So for whatever reason, it can be autoimmune, it can be genetic, it can be iatrogenic, either after surgery for an ovarian cyst that's been removed, that removes part of the germ cells that are essential to stimulate to grow eggs. It can also, when I said autoimmune, that is rheumatoid arthritis or systemic lupus erythematosus. Those things are associated with premature ovarian insufficiency. A final one I alluded to earlier as well is chemotherapy or radiation that can impact premature ovarian insufficiency, and by definition, it is the cessation of menses prior to the age of 40. Finally, hormonal imbalances. So when there is polycystic ovarian syndrome, where there is unopposed estrogen and no ovulation, so no progesterone, that can occur. There are hypothyroidism, for example. So if a person doesn't realize that they have had a goiter, or they're feeling sluggish or lethargic, and we do a check of their thyroid hormone, we can notice sometimes that not only antibodies to the thyroid are elucidated, but also hypothyroidism can be uncovered. And that can be corrected, and that is intimately linked to a patient's ability to ovulate. So solutions for this: we use medications to treat the illness. We can combine a controlled ovarian stimulation with inseminations, or controlled ovarian stimulation with in vitro fertilization, where we take eggs and sperm and then fertilize them in a petri dish and grow them in a laboratory, along with genetically testing them to find out whether they're euploid or aneuploid, and then at a later date transferring only the healthy euploid embryos into the uterus one at a time. Okay? And that's called elective single embryo transfer. In the old days, we used to transfer many embryos because we didn't have information about the genetics of the embryos. Now, with our ability to grow embryos to the 5th day of development, to the blastocyst stage, and also to understand about the genetic integrity of the embryos, we are making patients more pregnant with fewer embryos in a shorter amount of time. It's essentially mechanical obstruction of the tubes, and there are some medical issues that are more commonly causing the tubal infertility. So one of them I mentioned earlier, endometriosis. Remember I said the inside of the uterus located in ectopic locations. One of them is on the tubes. It can cause stickiness and occlusion of the tubes, and therefore tubal factor infertility. Another one is if someone has had a pelvic infection. So the common ones that we see are sexually transmitted infections, chlamydia, gonorrhea, and so sometimes, or even pelvic inflammatory disease where people get a big disease and they end up with abscesses on their tubes or in their ovaries. And so this essentially causes stickiness or scarring of the tubes and prevents them from mechanically functioning. Okay? And sometimes patients have had prior gynecologic or pelvic surgeries that result in adhesions, which are kind of sticky scars which happen in the pelvis, which can obstruct the tubes as well. I should mention that endometriosis that's associated with tubal obstruction is more likely the more severe disease. So endometriosis has 4 stages: stage 1, minimal, 2, mild, 3, moderate, and 4, severe. It's usually the patients that have either moderate or severe disease that have tubal obstruction. Okay? And the solution to this, of course, when the tubes are obstructed, you don't need tubes to get pregnant as long as the uterine environment is intact and the contours are anatomically correct. So you can create an embryo in vitro and grow it in a laboratory and then transfer it into the uterus. The one thing I will say is that if a tube is dilated or distended, is a hydrosalpinx or a pyosalpinx, that needs to be surgically managed before an embryo is transferred back. There's organic pathology that can happen or occur in a uterus. The common ones are polyps and fibroids. We see them a lot. And in as much as polyps are concerned, they're generally small, and they aren't always of value to remove. If they're less than 5 millimeters, they're not necessarily causing an issue in the expensive real estate of the uterus. However, if they are larger than 0.5 centimeters or 5 millimeters, they should be removed hysteroscopically. Then you also have fibroids. Fibroids are growths or myomatous, so they're tumors of the uterus, but what happens is that they can grow in different locations. So not all fibroids impact fertility in the same way. There are the fibroids that are pedunculated on the external aspect of the uterus. There are the fibroids that are intramural, so in the wall of the uterus. There are the fibroids that are submucosal or inside of the uterus. And then there are also those that are subserosal, just underneath the surface of the peritoneum that coats the uterus. So ultimately, the ones that impact fertility are the ones that are the submucosal one or type 0 ones. Those are the ones that are located inside the endometrial cavity proper. And the solution to these is to remove them hysteroscopically. Now, that's a type 0 fibroid. There's also type 1 or type 2 fibroids, and those are the intramural fibroids that impinge into the cavity. So if they're impinging into the cavity less than 50%, they don't need to be removed. However, if they're significantly impinging on the endometrial cavity, they must be removed, and that requires a myomectomy. And sometimes that can be accessed laparoscopically, and sometimes that needs to be done via laparotomy open. Other causes are what we call Mullerian anomalies. So approximately 3 to 4% of women have unusual shaped uterus, and unusually shaped uteri, and that comes from the development embryologically. So there are paramesonephric tubes, or the Mullerian ducts, that come together and fuse. And if any of that direction genetically is done poorly or is impeded, what happens is you can have a variety of fusion defects. So you can have a unicornuate uterus, you can have uterine didelphys, which is 2 uteruses and 2 cervixes. You can have a bicornuate uterus, which can't be surgically corrected, or you can have a septate uterus, which can be surgically corrected hysteroscopically. So another solution, if you have a unicornuate uterus, is to do IVF with elective single embryo transfer to minimize the risk of preterm delivery, or have the patient assessed for the possibility of uterine or cervical cerclage to prevent the premature opening of the cervix in labor or in pregnancy. And then finally, if it's too complicated or non-conducive to pregnancy, we solve the problem by using a gestational surrogate, which also happens at a fertility center. So that's the end of my talk about the common causes of infertility. And I hope that this was useful today, and it was nice to have the conversation. Have a good day. Bye-bye.